My name is Dion. I am a clinical associate professor at the University of Massachusetts Amherst College of Nursing. Along with my colleagues Cherry Sullivan and Michelle Ferry from Hampshire Hope, a state-funded county opioid task force in Massachusetts, we developed an educational session for emergency department healthcare providers on caring for people with a substance use disorder. We have no conflicts of interest to report. At the end of this presentation, our aim is that the learner will be able to describe the emergency department's role as the first point of contact for engagement in harm reduction practice and self-care management for people who use drugs, and 3 ways that the emergency department healthcare providers can incorporate harm reduction practices into their care. Research and verbalizations from emergency department healthcare providers shows that emergency departments are seeing increasing numbers of people with substance use disorder, and that the providers often lack the training and resources to assist this population. Both the person with a substance use disorder and their family member need support through recovery. The World Health Organization has identified stigma and discrimination of people who use drugs as a health disparity and area to be addressed. Emergency departments are often the first point of contact for many who have a substance use disorder, and this environment can set the stage for future healthcare interactions. Since substance use disorder is a chronic and relapsing brain disease, the emergency departments often sees people numerous times for issues related to their drug use. However, the literature has identified that emergency department healthcare providers often feel unprepared to provide harm reduction education and referral services for a person with a substance use disorder. Initially, we queried staff at 5 local emergency departments to inquire about concerns they had regarding caring for people with substance use disorder. The myriad of responses ranged from a supportive tone to a stigmatizing and discriminating one. We were able to review the feedback to look for themes. In addition, the literature and information from people with lived experiences were also used to develop the presentations. For each hospital, a tailored presentation was developed that addressed their needs based on feedback from their surveys and discussion with their unit manager. The time allotted for the presentation was also a factor. For 2 emergency departments, the manager made the presentation part of the monthly mandatory meeting. For the others, staff were invited and encouraged to attend. The presentations ranged from 60 to 90 minutes, and this was based on the emergency department's needs and availability. We titled the presentation, Recognizing Addiction and Supporting Patients and Their Family Members Through Recovery. We wanted the title to be inviting and action-oriented, as this was how we had planned the content. At the beginning of each presentation, we acknowledge the current conditions and legitimize the experiences of the clinicians and staff. Our state is now in the top 10 for opioid overdose deaths, but had recently been in the top 5. We began with a 3-minute video of a local addiction certified provider's explanation of the physiology of addiction. We wanted all in attendance to be aware of the science that we have seen with addiction, as we are acutely aware that most all of us did not receive the education regarding addiction that is really needed to perform our jobs. I then moved on to trauma-informed care. This provided an opportunity to share the research I have done with people who use drugs, what the literature says, and findings from the adverse childhood event studies that have been done. This information was also addressed in the physiology of addiction, so this can assist with the false belief that people choose to be addicted. This topic led me into sharing some of the quotes from people who inject drugs about the care that they had received from healthcare professionals. I shared an example of an individual that eloquently articulated the stigma and discrimination they experienced, and then balanced it with another quote where the individual shared how they felt that they did not feel they were treated any differently than others receiving care. I then showed how language matters and that stigmatizing language hampered an individual's recovery. Having a visual where the clinicians and staff could see the stigmatizing language and have it replaced with person-first language was something that was verbally appreciated by the group and also written in their evaluation comments. I intentionally chose words that I found that were used in the original surveys or I've heard being used in the emergency department. I tied this language back to the trauma-informed care principles, as research has shown the high rate of emotional, physical, and sexual abuse that people with a substance use disorder experience in their life, and how these multiple trauma events are connected to mental health and substance use disorders. Relapse and stages of change were two areas that I recognize would be trigger points for the clinicians and staff due to the high number of repeated overdoses they see just in one day. As I showed them this visual, I was able to explain that what we expect is often not what happens when one is on the path of recovery. I provided examples of other ways that people relapse that the attendee could understand and relate to, such as smoking, dieting, exercising, or maybe even spending more than they could afford. It was at this time that I would introduce the findings from the 2014 Journal of American Medical Association that showed that the relapse rates for those who have hypertension and asthma were higher than those who had a substance addiction. Providing the anecdotal information as a peer who has walked in their shoes allowed me to connect with them by gently reminding them of the many times we see individuals who've had numerous emergency department admissions due to their CHF status. We know from the data that often this is due to medication and a diet adherence. When we talk about relapse, we are talking about the act of backsliding or worsening. We see this in healthcare all of the time. I would then show the stages of change model that we are also familiar with, as this provided an opportunity to show how we can meet people where they are at. I would highlight examples of behaviors that the clinicians and staff could implement at the various stages. For example, if an individual was at pre-contemplation, this was an excellent time to implement harm reduction measures, such as asking if the person had naloxone or was aware of the nearest syringe access program to obtain clean and sterile supplies. Although harm reduction education should be implemented at all stages, it is especially important for those that are not able or ready to change their substance use behaviors. However, the education that occurs when someone is in preparation or action looks different and will be received differently. An example would be at this point, sharing resources or information about medication-assisted treatment or detox programs would be heard differently by the person at this stage. It was important that the staff knew that just because a person wasn't ready to receive information about medication-assisted treatment or detox did not mean that the seed couldn't be planted. I would provide the staff with the language they could use, such as saying, "I'm glad you're here. Thank you for telling me that you aren't ready for detox or MAT. Please know that if and when you are, there are area resources that you can use to help you to access these services." Using language that was trauma-informed, person-centered, and respecting of an individual's autonomy was a great way to build relationships. There was a great point where I was able to acknowledge that we all entered healthcare because we wanted to help people, and that for situations like this was helping the person, as decreasing the stigma they experienced and developing an interpersonal relationship was a critical component of healing. Providing examples of where harm reduction information could be shared was another area that was well received by the clinicians and staff. Engagement could occur while obtaining a blood pressure. You could ask, "Can you tell me about your injecting practice?" This is an opportunity to examine sites, ensure that the individual is using proper technique, how to avoid soft tissue trauma and abscesses, and to provide one-time, one-use, no-sharing education. Research has shown that people who inject drugs want their providers to ask to see their injection sites. Providing education about syringe access programs, if available in your area, is essential, as research shows that those who access these sites are 5 times more likely to enter a recovery program than those that don't access these sites at all. During the presentation, I demonstrated a 3-minute video about how the clinician could incorporate motivational interviewing, harm reduction education, and non-stigmatizing language. Seeing this allowed for me to illustrate how this could occur during a short period of time, as lack of time was a common theme in the surveys as a barrier to providing care to the person with substance use disorder. One of the barriers to care that came up several times during the presentation had to do with managing withdrawal symptoms and getting folks into treatment during off shifts. I was able to share the regulation that allows emergency department physicians to prescribe buprenorphine once a day for a total of 3 days without having a buprenorphine waiver. This information generated a lot of discussion, as several of the nurses felt disempowered because they worked with providers that did not share the same non-judgmental attitude they had towards people who use drugs. Finally, representatives from area resources took a few minutes to inform the group about who they were and the services they provided. These resources included recovery coaches, staff from the Syringe Access Program, and a DART police officer. DART is the drug addiction response team that is part of Hampshire Hope's intervention for opioid overdose in the state of Massachusetts. All emergency departments were provided with a 1-page resource sheet to be able to provide referral to patients and their family members. This easy-to-use reference was identified as a welcome tool for the clinicians. Our group evaluation of the trainings showed that this information was very much needed and appreciated. Engagement among the attendees was active at all of the trainings and provided us with insight as to the points that generated the most discussion and interest. Hearing someone say that they never knew about the addiction pathway in the brain provided validation to others that this is new information that would not have been learned in school. The team used verbal and nonverbal cues from the group to also assess responses to the information. We collected anonymous survey data from each presentation. The results were overwhelmingly positive. The attendees were asked to provide feedback about specific aspects of the training that they found helpful and what they learned from the session. It was through these evaluations that it became apparent that the clinicians expressed feelings unprepared to care for the person that uses drugs, but that they now felt that they had some tools in their toolkit to be the caregivers that they wanted to be. There were a number of comments about appreciating the stories and quotes that I shared from my research to show the positive impact that the nurse had on the person who uses drugs when non-judgmental care was provided. We learned that these types of trainings are necessary and helpful for supporting people with substance use disorder and their family members. Healthcare providers are often overwhelmed by the complexity of the patients they care for, and having easy to incorporate and useful information supports the clinician, patient, and their family member. Making their job as easy as possible and providing a visual of how to incorporate harm reduction education throughout their interactions with the individual made it easier for staff to conceptualize how to incorporate this into their work. The trainings were overwhelmingly successful, and the unit managers continued to work with the team to provide additional trainings to other members of the hospital.